Health inequalities, health equity, intersectionality, concepts that have been flying around increasingly recently. But how central and embedded are such considerations in health research? And if they're not, should they be? And how do we bring about such a culture change? I'm joined today by three proponents of health equity, but also critical thinkers all around. So I can't wait to hear what they have to say. With us, Dr. Stan Papoulias, Research Fellow at King's College London and ARC South London. Hello, Stan.
Yeah, hi, Katerina. So I'm Stan Papoulias. As Katerina just said, I work at King's College London. I'm a research fellow and I'm funded externally, that is to say, from a National Institute for Health and Care Research grant, the Applied Research Collaboration, South London. And I'm also a user survivor researcher, a mental health user survivor researcher. I'm, in fact, part of a research group at King's called SURE, or the Service User Research Enterprise, which is staffed almost exclusively by people with either experience of mental distress and maybe a psychiatric diagnosis, or people who are neurodivergent, and that is used as a research tool. What we're trying to do is to bring a sort of perspective from lived experience into research, primarily on mental health. But because of the way I'm funded, I work in patient public involvement research across health areas.
And we also have with us Savi, Hensman, Patient Service User Carer and Public Involvement Coordinator, also at King's College and ARC South London. Hello, Savi.
I have been working for a number of years now in supporting patient service user carer and public involvement in health and social care across a range of themes in Applied Research Collaboration, South London. My background is mainly in the voluntary sector. I have been a community worker and activist, and for many years was supporting involvement in health and social care planning and delivery, largely supporting patient and service user organisations and representatives, as well as sometimes working with statutory bodies at a local and national level, trying to extend and strengthen involvement. I am also used to living and working in areas of high diversity, socioeconomic, cultural, ethnic, and in many other ways, with high levels of deprivation and discrimination, which quite clearly affect people's health and well-being, as well as their access to services that can offer support. And South London reflects some of that diversity.
And then, last but not least, Dr. Anna Porroche-Escudero, who's a lecturer in health research at Lancaster University. And she used to be me, I'm now her. We're still figuring that out for the ARC Northwest Coast. Hello, Anna.
Thank you. Thank you for inviting me. So I just say I am a lecturer in health research here at Lancaster Uni. My background is in critical medical anthropology, gender studies, and I've been working on global health and public health. As you mentioned, I used to work in the ARC, and with Jenny Popey, we developed a theoretically informed approach to embed a health equity focus in research. We coined that health equity mainstreaming, and that was very much based on gender mainstreaming. When Jenny and I started doing the work on ARC, we really didn't know what we were trying to do mainstreaming, but as years went by, we thought, what we are trying to do here is making equity a golden thread, and that's why we coined it health equity. So we didn't start with those glasses. It became apparent as we started working with different colleagues, and I am thrilled that you, Katerina, took a relay, and you are doing an amazing job to infect others.
Thank you, Anna. You realize that's the part I'm going to cut out from the podcast. But Anna, that is amazing. And that's definitely something we're coming back to. But before we get fully into it, I want to start by asking you all, because there's been an increase in talk about health inequalities and equity, if not before COVID, definitely afterwards in lots of different sectors and places and people. And in your personal experience, how did that interest in equity and into intersectional sensitive research develop for you? And like, where did it come from and what do you feel is driving it?
I guess I don't really think about my work precisely in those terms. I come from the humanities and the social sciences, and I've kind of migrated in later age to applied health research. So I came as a kind of an outsider. And one of the things that really struck me is how discussions about health inequalities were framed. And there's a lot of emphasis on individual behaviors or on cultural behaviors, which kind of goes totally against the way that we look at, let's say, social inequalities and people's actions and what makes people act the way they act in other fields or in cultural studies, in the humanities. And so I saw very little emphasis on structural forces. So, for example, issues around racism, sexism, and how particular kind of power dynamics, social power dynamics, construct or come together to produce particular social positions, which then have a lot to do with how people act and how people conceptualize the world around them. So this kind of structural aspects to health and social inequalities and the relational aspect that people are in relation to these systems, that seem to be not really a language to talk about this within applied health research. And that really struck me. And so there was a kind of interdisciplinary or cross-disciplinary clash, or sort of a surprise. And at the same time, working as a user survivor researcher, which is a type of research that, again, I was not familiar with until I came to King's and Shaw in 2012, is necessarily a position from which you start really thinking about inequity, particularly because people who use mental health services, I mean, the whole term service user is highly problematic when it comes to mental health, because it implies a kind of voluntary choice of services. It implies a kind of customer relationship almost. But in the case of mental health, psychiatric services, this is not always the case, because a lot of considerable treatment is compulsory. We're talking about psychiatric detention or sectioning in this country and so on. And that kind of compulsory treatment is differentially applied in terms of different kinds of populations. So we find, for example, that in the UK, disproportionately, the population who are more likely to be sectioned in psychiatric wards tend to be men of African Caribbean heritage. And so there is this kind of obvious sense of health inequity that kind of relates very closely or maps onto social inequity. And this is immediately an open issue. The third thing I wanted to mention is PPI, or patient and public involvement. So I've been working, as has Savi, in different ways within the context of patient public involvement, which is increasingly a mandatory aspect of health research, particularly, but not only applied health research in the UK as it is elsewhere. And the whole principle of doing involvement is about bringing lived experience to make research more relevant to the populations to which the research is aimed. So within it, this idea of patient public involvement has or should have elements of social justice. But in reality, that is not always the case. Often it isn't the case, in fact. So all these kind of three areas of personal experience, of academic experience, and of medical experience as well, as someone who has a psychiatric diagnosis myself, have brought me to this space, although I wouldn't call it necessarily a space of intersectionality, but inequality, social justice, and so on.
I think for those of us originally from the global south and of global majority heritage, very often some of those inequalities in society which affect health and access to care are quite stark and have been talked about and written about and contested and challenged in various ways. So this is part of that background of discussion and awareness, I think. But it's also often quite evident in the UK and other countries in certain sections of the population. I've been a carer for a very long time in health and care circles. It can be quite obvious sometimes, though there are also more subtle ways in which injustices of various kinds can interact to affect people's health and well-being, but also can have a broader impact on communities, on neighbourhoods, and the whole environment in which everybody lives. Though we can come to see those inequalities are so ingrained, we just take them for granted. And a lot of us have had to struggle to learn to feel good about ourselves in a world where social injustice is so common. I worked from 1985 to 1994 for the Black Lesbian and Gay Centre project, and that was a very valuable experience. And in those days, the terminology of intersectionality, I think, was just being coined. It certainly wasn't widespread, but it was quite evident that it wasn't just a matter of adding up different kinds of injustice. Oh gosh, you must be very, very oppressed if you're a woman or a lesbian or black or minority ethnic or disabled and so on. It wasn't about a hierarchy of oppression or just adding different strands together, that there were various ways in which those might interact and which were very much tied up with the way in which society worked. So looking at that could throw wider light on issues that affected everybody in one way or another. So I had that experience and was also then working within the local voluntary sector, often with people in public health. And so I think there was a wider awareness in that field of the impact of inequalities and various measures to challenge those. But of course, these kept coming up against some of the structural barriers to making deep-rooted changes. So I think that was the background against which I came in many years later into the ARC. And at that point, there was awareness of the importance of challenging inequalities and how these might affect a range of local people, or some sense that this was something important to take on board. But also research culture and structures can make it that much harder to root oneself in communities, to listen to what people are saying, to work alongside those who are challenging injustice from the spaces that they're in, and drilling down into some of the issues that affect people rather than just looking at interventions. And I think it is important to do what we can where we are against the background, which is often less than ideal, but at the same time keep asking those searching questions. And hopefully that's something that is gradually developing in the health and social care research field, though there's continually that pressure just to find something that will make things a bit better for the time being for some people, and that's important as well, without taking on board some of those more tricky issues and some of the challenges in actually drilling down when so many different things may be going on in people's lives and the lives of their communities, which affect their health.
I am where I am in terms of health equity mainstreaming and intersectionality. It has been a bumpy ride, exciting but quite bumpy and challenging. But two main things for me. As I say, when I was hired in the ARC, my main role was basically to develop a toolkit to help researchers thinking about inequality. But as we progressed, we realized that we wanted to do something else. And we saw that for many colleagues, this is unwitting. So people are not malintentioned. This is unwitting. Sometimes colleagues, they work on an automatic pilot. So we realized that health inequalities were thought to be research done by a specialist unit. Some people will say, I work on personalized medicine or mental health or cancer. Health inequalities is not my area. And we started thinking health inequalities is everybody's areas. It doesn't matter what methodology you use, what topics you are working on, everything is connected to health inequalities. So we started realizing that to change that kind of mindset, we really needed to do a cultural mindset change too, because it's not enough with telling colleagues why you don't engage with health inequalities, it will benefit your research. Sometimes you need a cultural change in the organization. So that started triggering some thinking about the way we could do things differently in our ARC. So that was, for me, a quite big realization. We wanted to do cultural change, We wanted to embed health inequalities in the structures and processes and every single activity of our organization. So it was going beyond doing one-off individual little pieces of research. It had to be embedded in the core of the organization. That was one big thing. And the other big thing is that when I was reviewing or supporting colleagues to embed health inequalities lens in their work, I realized that many colleagues were conflating or confusing some concepts. So they came to me, they wanted to research migrant women's health or people living with diabetes or people with learning disabilities. So they were homogenizing the experience of individuals who have a health condition, that this health condition is linked to health inequalities. So they were bringing these big people with health conditions like learning disabilities, diabetes, women migrants, cancer, and these conditions are really linked to health inequalities. But they were treating all those big groups as something homogeneous, as something static. And I was trying to engage with colleagues saying, actually, within the category of women's migrants, there are huge differences, And I always give my example. I am a white migrant in the UK, but I am white, I am from Southern Europe, and I have high qualifications. So my experience is very different to the experience of other women. We do need to have into account those differences rather than homogenizing groups. And that was a consistent issue I saw once and again and again. And it was quite like, how do I explain this to the colleagues? So hopefully we did a better job later in our health equity strategy. And the third point is linked to my second point. When people started thinking, oh yes, we should not homogenize groups because there are differences within. So where I start seeing is that people will think race or gender or sexuality. But if you don't do that properly, there is a high risk that you blame gender per se, you blame race per se. So what I was trying to talk with colleagues is that gender is not the problem. The problem is sexism. Race, my skin color, my accent is not the problem. The problem is racism. So that was a big thing that I think that for me, the concept of intersectionality brought that to the fore, Be careful with adding those social identities in isolation because the results can be blaming ethnic groups for their own problems, if we don't think about racism. So these 3 points were they were boiling, in Jenny Popeye in my head. And that was right, we need institutional change. We need to ask colleagues to start thinking about differences within groups. And we need to start thinking about systems of oppression rather than gender or my age per se. And that's when we crafted the strategy to try to help colleagues to think about those things, whatever they did, anything really.
All three of you have now answered lots of questions I had, but raised so many more in my head. You all alluded to a change you've also noticed in the language over time. How have you experienced that shift in language over time, and why has that happened, let's say? Well, where do you see the drivers of that change? So how does change happen around us, I guess, before we try and create it ourselves?
I would say that perhaps some people were addressing issues that we might now describe as intersectional, even before the term intersectionality became widespread. So I think it's recognizing that some of that work has been going on for a very long time and often rooted within the experience of communities, especially where perhaps health and social care professionals and researchers have either arisen for or are embedded in those communities or have been working closely with those communities, those sets of people with particular health and care conditions or discrimination in order to challenge and combat these. So some of it is around terms becoming identified and more widespread in health and social care research, sometimes moving from one research field to another, I think, but also growing recognition that attempts to change health status that don't tackle social issues may end up making some difference, but leaving huge disparities with time.
Disparities, there's another word for it.
I mean, it's really interesting to trace how particular words become common and travel between disciplines or travel from different areas. The Palestinian-American philosopher and social theorist Edward Said talked about this back in the early 80s, about this move as a traveling theory. That is when particular kind of concepts move across domains. Now, they may move from activism to the university, or they may move from one discipline to the other. And I think intersectionality is one of those words. Another one is co-production. And they become very, very common. So you start seeing policy documents with both intersectionality and co-production. You start seeing organizational websites having kind of policy or strategies around involvement is another one, patient involvement, co-production, intersectionality. And I guess the question there is, what happens when these concepts travel? What are the effects that they have? And how much of the intent changes in that travel? And in terms of intersectionality, there is a sense that often it is used or can be used as an alibi. And that's something that I've seen a lot with inclusion, for example, diversity and inclusion, where you have words like intersectionality, diversity and inclusion, co-production being sort of front and center to give a kind of a moral foundation to the mission or the aims and objectives of research, of organizations, of policies. Whereas in fact, if you look at what is happening, there is very little that has taken place in terms of what Anna was talking about, culture change or systems change or a kind of structural understanding of what it would mean to embed an intersectional perspective, to embed co-production, to embed inclusion within university spaces, research spaces, healthcare spaces, and so on. I think we need to be really careful about what work these words are doing, and are they working as an alibi, as a front for not changing anything, if you see what I mean.
From personal experience to professional practice to academic theory and back again, This has been the iterative journey to equity for Savi, Anna, and Stan to date. Listen to part 2 of this episode, where we talk about structural, systemic, and culture change to mainstream equity.